Walk into any K-12 classroom and the disruptive student instantly commands attention. But the real crisis happens in total silence, right in the front row, where a student is quietly erasing a hole through their assignment sheet. On the outside, they look focused. Under the surface, they are operating with a racing heart rate, severe sleep deficits, and an internal loop of uncontrollable worry. Look at the data. This chart shows the massive scale of childhood generalized anxiety disorder, or GAD. It affects approximately 1 in 10 U.S. youths, with a lifetime prevalence specifically for GAD sitting near 9%. Despite those numbers, this condition constantly flies under the radar of educational professionals and caregivers. Our systemic model of what makes a good student actively masks one of the most widespread and damaging pediatric mental health crises we have. The core problem is structural. Well-meaning educators and parents consistently look at clinical symptoms and miscategorize them as benign personality traits. When a child obsessively redoes their work or asks for constant reassurance, adults naturally assume it is a sign of a type A personality or a drive for perfectionism. When that same child complains of a stomachache or a headache before every test or social event, we send them to the nurse to rest, treating an isolated illness instead of a physical marker of anxiety. To solve this, we must deconstruct the strict pediatric DSM-5 criteria, map the differential diagnoses, and integrate actual clinical interventions into our K-12 infrastructure. Without a rigorous clinical framework, educational systems will continue treating superficial symptoms while completely ignoring the neurological root cause. The school environment makes it easy to excuse these behaviors, but the DSM-5 criteria does not. The baseline requirement for a GAD diagnosis is excessive, difficult-to-control worry about multiple everyday events, occurring for at least 6 months. As this matrix shows, for an adult, the worry must be associated with at least 3 physical or cognitive symptoms, like restlessness or muscle tension. But a child requires only 1 associated symptom to meet the clinical threshold for a diagnosis. Under this single symptom rule, we might see sleep disturbances, persistent physical fatigue, or constant need for reassurance. Because the math of the diagnosis requires fewer outward symptoms, pediatric GAD presents quietly. It escapes disciplinary notice because the child is imploding, not exploding. You cannot diagnose this condition through an observational guess by a teacher or parent. It requires a licensed clinician using validated measures, like the SCARED assessment or the GAD-7. Clinicians must navigate overlapping mental health presentations. Behaviors like restlessness and poor concentration map cleanly to both GAD and ADHD, causing frequent misdiagnosis. Separating them requires identifying the invisible driver. Is the lack of focus caused by executive dysfunction or by internal, uncontrollable worry? They must also isolate it from separation anxiety, which is strictly caregiver-focused, and social anxiety, which is a specific fear of peer evaluation. Misidentifying the underlying mechanism, like giving an anxious shiver. Once a diagnosis is made, the behavioral interactions between the student and their adult caregivers become the deciding factor in their recovery. This accommodation loop chart shows how it works. When a child worries, the instinct of adults is to rescue them with avoidance or reassurance, yielding temporary relief. But this has a catastrophic consequence. It rewards and reinforces the anxiety loop for the future. The long-term stakes of this reinforced, untreated GAD are severe. It is a primary predictor of adolescent depression, severe adult anxiety, and chronic academic absenteeism. Intuitive, highly protective responses from well-meaning adults actually function as systemic enablers of the disorder. Breaking the cycle requires hard, evidence-based clinical interventions, beginning with cognitive behavioral therapy. Manualized programs like Coping Cat offer a strict 16-session approach for children ages 7 to 13. It focuses on cognitive reframing and gradual, controlled exposure to their feared triggers. When behavioral therapy alone is insufficient to break the loop, pharmacological interventions are the necessary next step for moderate to severe cases. Specific SSRIs, including fluoxetine and sertraline, hold strict FDA approval for safe pediatric application. Look at the findings from the landmark CAM study. This bar chart proves that while individual treatments work, a combined approach of therapy and medication yields the highest success rate. Resolving pediatric GAD demands a structured, multimodal medical approach. Unstructured ad hoc school counseling cannot fix it. Applying these complex clinical realities to everyday life requires a significant macro-level adjustment to our K-12 educational infrastructure. Schools rely on 504 plans to support students, but administrators have to walk a strategic tightrope. They must offer vital accommodations like extended testing time without allowing the behavioral avoidance that maintains the anxiety. The major logistical hurdle is time. Bridging the gap between the child's intensive clinical needs and restrictive school hours requires integrated teletherapy. The MentalSpace school model solves this directly. By providing K-12 systems with dedicated therapist teams, same-day access, and Medicaid compatibility, they embed the clinical response into the school day. Achieving this level of infrastructure is rapidly becoming an administrative necessity, particularly to maintain compliance with state-level mandates like Georgia's House Bill 268. Schools can no longer merely refer a struggling student out to a private clinic. They must become active, legally compliant partners in the therapeutic infrastructure. K-12 systems must stop misidentifying these symptoms as perfectionism and start implementing rigorous clinical protocols. Intervening earlier and with clinical precision dramatically improves outcomes and permanently prevents secondary adolescent depression. Pediatric GAD is a measurable neurobiological disorder. It is an illness, not an inherent personality quirk. Educational administrators and K-12 clinicians must train themselves to look past the illusion of the quiet, perfect student. Sustained educational achievement is only possible when schools construct the clinical systems required to identify and treat the underlying